Hello everyone, I'm Richard Stubbs, and as Chair of the Clinical Engineering Specialist Interest Group of the UK's Institute of Physics and Engineering and Medicine, I'd like to welcome you to the UK's contribution to Global Clinical Engineering Day 2018. Our contribution this year will be in the form of a series of 4 pre-recorded video presentations from contributors in the UK around the theme of overcoming challenges in health technology assessment and adoption in the UK. We hope you enjoy hearing their stories. Our first speaker is Professor Dan Clark, Director of CHEATA, the Centre for Healthcare Equipment and Technology Adoption. He'll be giving us a valuable insight into how early health technology assessment can make or break successful product innovation. Our second speakers are Professor Andrew Weeks of the University of Liverpool in the UK and James Ditai of the Sanyu Africa Research Institute in Uganda. They'll be talking about the introduction of the BabySaver neonatal resuscitation device. Our third speaker is Professor Azzam Taktak of the University of Liverpool and the Royal Liverpool Hospital. Azzam will give a short lecture on the principles of artificial intelligence systems, with some practical examples of their application in healthcare technology. Our fourth and final speaker today is Murali, the lead clinical technologist at Nottingham University Hospital Clinical Engineering Department. Together with colleagues from his service, he'll be sharing experiences in managing medical devices and equipment in clinical practice, looking at aspects that assure they are introduced and used safely. So let's move on to our first speaker, Professor Dan Clark.
Thank you very much. I've got to confess, I'm ever so slightly nervous right now. I've been walking around the conference this morning and I've been looking at some of the fantastic things out there. And my sense of anxiety has been growing as the morning's gone on. Not because you're a particularly rough crowd on the whole, but because I've been asked to talk about the value proposition. And the value proposition itself is really quite a simple concept, quite a simple idea. And I'm looking around this conference, and I'm looking around some of these stands, and I'm thinking to myself, you guys probably know more about the value proposition than I do. So what am I doing standing on the stage talking about it? Because the value proposition is something that, whether we're in business or not, whether we've got a medical device product or not, whether we're in the game of selling stuff or not, is something we're all very familiar with. I'm no doubt going to do a bit of value propositioning myself on the way home tonight, thinking it's been a long day and a long week. I might well stop at Sainsbury's on the way home and get a bottle of wine for my tea. And as I walk into Sainsbury's and go down the shelves and look at all the bottles of wine, I will be doing a calculation in my head around the value proposition. I'll be saying to myself, what sort of wine do I want tonight? Do I want a New World wine? Do I want a French wine? How much am I prepared to pay for that? Do I want a fancy label to impress my guests? Do I want a fancy grape or whatever? And as I'm doing that calculation, as I'm doing that reasoning, I'm going to be thinking, how much am I prepared to pay for this bottle of wine? Of course, Sainsbury's have already done that calculation for themselves. They've been thinking, what sort of a sucker am I going to be walking into Sainsbury's today buying my bottle of wine? They'll be trying to catch me in with all sorts of clever things. So this idea of the value proposition is something which is very familiar to all of us, to all of you. So what's the point of having somebody like me stand on the stage today and talk about the value proposition to a bunch of people who probably know more about it than I do? Well, my 30-something years experience in the NHS has taught me that on quite a lot of occasions, people with really rather clever medical device ideas and medical device products don't actually understand the value proposition of their device, or if they do understand it, they're not very well equipped at being able to explain it and illustrate it in a language that the people who are going to buy it, or they're hopefully going to buy it, will understand. So we found out in our game that actually describing the value proposition of a medical device, a medical technology, can be quite tricky. So this afternoon then I'm going to do just really introduce you to 3 very simple tools, and they are almost embarrassingly simple, as you will see in a minute. 3 very simple tools that we've developed in Nottingham to help people describe the value proposition of their medical device, their medical technology. I perhaps ought to start by explaining the split personality that I've got at the moment. I noticed I was introduced today, thank you very much for the warm introduction, as coming from Nottingham University, which indeed I do. I work as a professor at the university where I help a lot of people translate their ideas for medical device technology into the real world of the NHS. So I do work at the university. But my main job, I guess, is as head of service at the hospital in Nottingham, Nottingham University Hospital NHS Trust. My badge says that I'm from NICE. And indeed, I do work at NICE for a couple of days a month, helping them on adoption recommendations for new technologies into the NHS. But what I'm going to talk about now is around what CHEATA do. And I should just quickly explain that CHEATA was an organisation that we founded in Nottingham about 3 years ago. CHEATA is the Centre for Healthcare Equipment and Technology Adoption. And CHEATA was specifically designed to help manufacturers, notably small manufacturers, understand the pathway from concept to adoption and diffusion of technology in the NHS, and provide a range of services and products for manufacturers, for particularly small manufacturers, in helping them to do that. And one of the key areas that CHEATA have worked in is this idea of describing the value proposition. And like I say, we've got 3 key steps, and they are very simple, but very important to understand and get right. And they are what we call the matrix, framing the claim, and then the WWW of medtech adoption, which is the who with what. So I'll talk through those very quick steps now, and then I'll illustrate them with 3 examples. The matrix then is so simple, embarrassingly so, that we've tried to jazz it up with a flashy name and a flashy slide now to make you think it's more important than it is. It is simple. It is nothing like as complicated as the plots and subplots that poor old Keanu and his mates had to delve through within the film. It is a simple device. Before I describe that simple device, I'm going to introduce you to 2 concepts which you probably know, and you could probably describe to me, but I'm going to bash on with it anyway. The first of those concepts is patient benefit. Now, intuitively, we all know what patient benefit is. Patient benefit is doing something which improves either the outcomes or the experiences or something to do with helping the patient feel better about themselves. So we know what patient benefit is. You can ask anybody. You can ask a doctor, you can ask a nurse, you can ask a physiotherapist, you can ask anybody in the stands outside here what's patient benefit, and they'll be able to describe that to you. Measuring it, quantifying it, putting a number on it might be more difficult, but people instinctively know what patient benefit is. The second idea is healthcare system benefit. And again, we can probably all describe what the healthcare system is. The healthcare system is not just the single procedure, the single application of your technology where you use it. The healthcare system is the whole pathway that the patient goes through. So a patient turns up in the healthcare system and goes through a whole pathway. If we introduce technology, that's only part of the pathway, but it's the whole system that we need to be interested in. And I guess what I really mean when I say the healthcare system, I mean cash pound notes. I mean, how much does it cost the system to look after that patient? So we've got these 2 ideas. We've got patient benefit and we've got healthcare system benefit. If we introduce a new technology into the patient pathway, if you have a product that we can sell into the NHS, then it's going to have an effect on healthcare benefit, on patient benefit, and healthcare system. And in fact, if you put it into the system, that doesn't have to be a technology. If it's a drug, if it's a new way of working, if it's a new intervention, it's going to have an impact on patients, patient benefit, and it's going to have an impact on the healthcare system. Now, that impact might be good or bad. So it might be good for our patients, better than we do now. If you put in a new technology, and we've got lots of new technologies out there at the moment, if we introduce them into the healthcare, it'll probably improve patient benefit. So it might improve patient benefit. It might actually just be as good as what we currently do, the current technologies and the current ways of working. Or, strangely, there are some technologies which we might introduce which could be worse for our patients. They could actually have a detrimental effect on patient benefit. So there's 3 things that they could do then when we introduce that technology. And you can apply the same thing to the costs, the healthcare system. If we introduce a new technology, it might be incredibly expensive. It might push up the cost of providing care for our patients. Not just at the point that we provide that, but across the whole system, the whole care pathway. So it might push up costs, or it might cost about the same as it's currently costing to look after those patients, or it might be cheaper overall. So you can see, this is where the matrix comes in. If we plot patient benefit against healthcare system benefit, we've got 1 of 9 states that your new technology, your new intervention, your new medical device could have. The green squares are good news squares. So if you've got a new technology that we introduce into the healthcare system and it is better, it improves patient care, it's better for our patients, and it reduces the cost of the whole healthcare system, then you're in the top right-hand box of the matrix. And that's going to be good news. Why would we not, as the NHS, why would we not want that technology adopted into our healthcare system? Conversely, of course, if you're in the bottom left-hand square here, if you've got a new technology that when we introduce it into the healthcare system costs us a lot more money and is perversely worse for patient benefit, then nobody wants that, thank you very much. If you're in the business of making a device like that, stop now and put your time and energy and skills into something else, because we don't want products in the bottom left-hand side of this graph. And then that middle diagonal there is what Jeff Boycott would call the corridor of uncertainty. If you're in that area, you may have a product that the NHS wants, but it's going to be hard work convincing the NHS or any modern healthcare system that it wants it. If you're in the, if you've got a product which is more expensive, but better for patients, well, sometimes we, the NHS, the healthcare system, is going to want that. But on other times, if you spend money on your product, the NHS has a finite and indeed reducing pot of money to spend on. If I spend money on your new technology, I've got to take it away from somebody else's healthcare. So that gap in benefits got to be much, much better for your new technology than for the existing one. So that is step one. If you've got a product, if you've got a new idea, if you've got a new way of working in the NHS, where does it sit in the matrix? If it sits in those green squares, fantastic. Let's develop that. Let's look at ways of taking that forward. If it sits in the red squares, I think you should take a long, hard look at that technology and decide whether you really want to invest your time and energy and skills in developing it. And if it's in the middle, well, we've got some work to do. Step one. Step two, then, is a thing that we refer to as framing the claim. I've been there. I'm still there, actually. I'm a research scientist by background and developed lots of new ideas. And when you're an inventor of a new idea, you think it is fantastic. You invest a lot of your time, your energy, your skills into that new idea, and it's the best thing since sliced bread to you. And we have a habit, when we've got to that point, when we apply that product to healthcare, of over-egging what our product can do. We tend to say all sorts of things that it can do, a whole pile of stuff. But actually, what's the core thing? What's the core claim that you're making for your technology in healthcare? What's the core thing? Don't try and suggest, it can also do a whole pile of other stuff. Think about the core thing, the key thing that the technology does. And I'll come back to that and illustrate it with a couple of examples. So step two is identifying the key claim for your product. Okay, yes, I mean, that's just an example there of also makes the T as one of the expressions that we use in some of our feedback to people. But they have products that can do absolutely everything, but you can only, we must concentrate only on those claims that we can back up with evidence. Don't suggest it can do things that we can't. Here's some typical examples of the 1950s of people making claims for products. I'm sorry, you can't see it from back there. In fact, the text is so small and blurred, I can't see it from back here. But this is an advert, as you can see, for a non-medical device, but it's an advert for cigarettes, and I love the fact that it talks about scientific evidence, Marky, not just any old rubbish evidence, scientific evidence, that there is no adverse effects of smoking this particular tobacco. If you can't read it, but if you look really closely, 45% of patients in this cohort, 45%, and you realise that the cohort is actually only 20, I'm showing you 45% of 20 is, reported no adverse effects. So that's scientifically proven evidence. So don't drop into the idea of making claims for medical device products, your new products, that you can't back up with evidence. Okay, and finally, who with what is the third step that we apply. And who with what is all about working out who are the payers, who are the people with the purse strings, who are the people you need to convince. If you've got healthcare benefits, if you've got patient benefits, it's fairly obvious that you can convince healthcare professionals. That's what we do in hospitals. We want things better for our patients. So if you've got evidence that it improves patient outcome, we're easy to convince. If your evidence, though, is that it's across the wider system and it saves money, most doctors and nurses and other healthcare professionals are not that bothered about that, but my general manager and my director of finance would be. So who with what is all about understanding who it is that you need to convince and what evidence do you need to put in front of that person to convince them that your product is worth investing in the NHS. It's all a bit abstract, so I thought I might try and illustrate that with a few examples of devices which we at CHEATA have helped, or CHEATA staff have helped. It's quite difficult for us in CHEATA because obviously by the nature of the work we get, we work as consultants to medical device manufacturers and new technologies, and all that information that we provide to them is of course confidential, so we can't give you, it's difficult to give you live examples. So the three examples I've picked are ones where CHEATA staff have been involved in supporting technology which has ultimately gone to NICE, which is what it says on my badge, has gone to NICE for adoption into the, for recommendation for adoption into the NHS. So the first example that, some of you may have heard of this product, is a product called the Inditherm. The Inditherm is a solid state hospital mattress for operating tables. We have a number of procedures in hospitals, particularly long theatre procedures, where keeping the patient warm is a problem, and a cold patient doesn't do as well. So we have to keep our patients warm, and there are conventional ways of doing that now, which generally about forced air. So they're basically big hair dryers and blankets that we keep our patients warm. Inditherm breaks into that market and says, you don't need to do that. The mattress itself warms up. It's a solid state device that warms up the mattress. When we looked at where does it sit on the matrix, we had to do quite a lot of work on this one. What's the cost and patient benefit? Well, we have clinical evidence that Inditherm, the solid state mattress, keeps patients as warm, not better, as warm as forced air warming. So it sits on the patient benefit in that middle column, but it's cheaper. It's not fantastically cheaper, but it's cheaper than using forced air warming. So in terms of where it sits on the matrix, it sits in the green boxes at the top. In terms of the claim, what could we back up with this claim? We couldn't claim that it made the tea, but we could claim that it kept patients as warm. As I said, not warmer, it's not better for our patients than forced air, it's about the same. But we had 5 published papers in peer-reviewed journals that said it's as good at maintaining the right temperature for our patients as forced air. So that's where it sits there, and we have cost models to demonstrate that we've worked up. Then in terms of the WWW, the who with what, who are we going to convince about this? This is a relatively straightforward new technology. It doesn't disrupt what we do in hospitals particularly. The operations take place in the same way. The patient goes through the same pathway. The only difference is we swap out forced air and we put in Inditherm. So it doesn't disrupt. So all we need to do is convince local clinicians that it's better and local hospital managers that it's cheaper. So that's what we did with the who with what. That was our target for that. So that was my first example. My second example, I like this example. I use this one a lot, mostly because I do a lot of talking about innovation, about new technologies. I do a lot of work with universities and bright people like yourselves who are coming up with new devices. And there's a temptation to think that all the solutions to the new healthcare have to be shiny boxes and go faster stripes and the latest whizzy stuff. This is one of my favorite devices because it brings a lot of healthcare benefits, reduces cost, and it is a dead simple low-tech solution. This device is called Pleurex, and as you can see, it is essentially a vacuum flask which comes with a small negative pressure inside it and then a number of catheters that we insert. What do we use it for? Well, there's a condition with, unfortunately, some patients with terminal cancer, particularly of the stomach and the lower intestines. These patients have terminal cancer, so we are giving them palliative care. But a consequence of their tumours is that they get a build-up of a fluid called ascites, which leaks into their stomach and makes the tummy swell up. This is uncomfortable, it's unsightly, it's smelly, and every few days that patient has to come back into hospital to have that fluid drained away. And that procedure means they have to take a day and come into the hospital, they have to take a hospital bed or an outpatient couch. They have to have a doctor or at least a practice nurse to do the procedure to drain it out, and then they go home again. And remember, these are terminal patients. These are cancer patients who have not got that long, and they don't want to waste what precious time they have got coming into hospital every couple of weeks to have this procedure done. So Pleurex does that for them. You wear it all the time at home, can be done by a district nurse, and it keeps the patient at home where they need to be. So in terms of a patient experience, where does it fit on the matrix? In terms of patient experience, it's way off the scale. It improves patient experience, patient care, patient benefit off the scale. In terms of where does it fit on the matrix from a cost point of view, a day procedure involving at least a nurse, possibly a junior doctor, taking up a bed in our hospital for a day, compared to staying at home with something which was, and I coined this phrase which has gone down in nice literature now as cheap as chips. In terms of costs for the NHS, for the whole system, this is ridiculously cheap compared to its alternative. So it's off the scale there. So it's in the very much top right-hand corner. In terms of framing the claim, again, we had a lot of clinical evidence for this. And the clinical evidence was all around that it was safe and it did the job. So we had 9, I think, yes, 9 published patients on that. And the cost model was easy. You could write it on the back of an envelope. But in fact, we did it very thoroughly. But it was an easy one to make. What was a little bit harder was the who with what. Because at the moment, all the costs for this procedure are in the acute centre. They're all in the hospital. If we introduce Plerex, all the costs and the difficulty and the care goes out into the community. And it's a different budget. So the acute hospital has one set of budgets, and the community sector has another set of budgets. And we've transferred the costs into the community there. So we couldn't just rely on, we did, but we couldn't just rely on convincing local clinicians. We had to convince the whole economy, local economy, of what the benefit of that was. So we had to get regional managers, the CCGs and Health Watch on board with that. So those were the people we had to aim at with the with the evidence. So that was my second example. And my third example was one of the most complex. So I've gone from one of the simplest to one of the most complex in terms of getting a recommendation. This device is called Watch BP, and it's actually just another non-invasive blood pressure meter. There are hundreds of them out there. You know the devices, you click them on the arm, you press a button, it inflates the cuff, deflates it automatically, listens to your pulse as it deflates, and works out what your blood pressure is. There's loads of these devices out there. What's special about Watch BP? Well, what Watch BP did was introduced an algorithm into this which looked at the pulse. Didn't just look at the crossing points. I will spare you the science behind how they measure blood pressure, but they looked at the whole pulse during this period. And usually the pulse is perfectly normal and everything's fine and dandy, and it just gives you your blood pressure measurement. But in a few patients, the pulse will be slightly erratic. And a slightly erratic pulse might be an indicator of AF, of arterial fibrillation. Arterial fibrillation is a key risk factor in having a stroke. So if you turn up at your GP and have your blood pressure taken with this device, if you're perfectly fit and healthy, you do that all the time. We do a lot of BP measurements, of course. Chances are it'll just give you your BP and that'll be that. No change to your healthcare. But you might just be unlucky and have AF and you don't know it because it's undiagnosed, and this device can spot that. So maybe 1 in 100 patients, it raises a little red flag and says, I think this patient might have AF. If the GP then sees that, the GP has to say, oh, I better refer you to the acute centre to do a 12 or a 7 lead ECG to double check whether you really do have AF. So maybe, you know, one of those patients, then, one of those 100 patients then gets sent to the acute centre, has the ECG, and may or may not be diagnosed with AF. If they are diagnosed with AF, they then get sent to the stroke team, who will think about, or the anticoag team, who will think about prophylactic treatments going forward for this asymptomatic patient to try and prevent them getting a potential stroke in the future. Where does Watch BP sit on the matrix? Well, in terms of patient benefit, it's slight in terms of the whole population. It's slight in terms of the whole population because maybe only 1 in 100 patients get detected on this, and those that get detected, maybe only 1 in 10 of them actually did have AF, and only a few of those actually get prophylactic treatment which prevented a stroke. So it's better for the one person that it picks up, but for the whole population, it's a small increase. In terms of costs, well, on the face of it, this looks like a really hard cost case to make. The Watch BP device itself is not the cheapest NIBP that you can buy. So you introduce costs there because the device itself is more expensive. About 1 in 100 patients get identified as potentially having AF. They get sent off to the acute centre. That's an expensive procedure that they have to have there to get the ECG. Of the few patients that get that ECG and a confirmation diagnosis of AF, they then go on to long-term chronic care to prevent them getting a potential stroke down the line. And that's more cost. So at every stage, we are introducing cost. It looks like there's no way we can make an argument. Except that if it avoids 1 stroke, it pays back. Not only is a stroke a disaster for the person who has it, and a disaster for the family of the person that has it on a personal level, it is a fantastic burden in terms of costs on the NHS to look after that patient for the rest of their lives. So avoiding one stroke can wipe out all those extra costs that Watch BP introduced. It was a phenomenally difficult cost case to make, but a cost case could be made. So that's where it fits on the curve. Again, in terms of framing the claim, we had good scientific data. We had a lot of things that said not only is this as good as any other NIPB machine, it can detect, in some patients, AF. In terms of the who with what, because of that very complicated pathway that only pulls back the savings in so few cases, we couldn't convince a local GP to pay more because the GP wouldn't see any cash pound note benefits. We couldn't even convince the local health community in, say, Nottinghamshire or Leicestershire or Coventry to do it because they wouldn't see the benefits. It had to be done at national level. So the only way to get this convinced was going up and getting nice recommendations to adopt this. So the value proposition is a very simple concept that we're all very familiar with and can do in our everyday life, but describing the value proposition of your medical device can be quite a challenge, and a lot of us are not very good at doing that. We at CHEATA have introduced these three really simple steps, really simple tools for identifying and trying to describe your value proposition. The first is the matrix, and that's the most important, really. The first thing you should do, even at the concept stage, even when you're still designing very early on in your product development, start to think about where will my product sit on the matrix. So the matrix is the most important. Claiming the frame sounds like common sense, but just don't get carried away and make claims for your device that you can't back up with hard evidence. And the final one is about understanding the complex nature of the NHS sometimes, and understanding who it is you need to convince with what type of evidence. And that's me.
When a baby is first born, it's critical that the cord is kept intact for the first few minutes. Now, there's a few babies who don't cry very well at all when they're first born and need support. Traditionally, you'd take them to a different room or bring them to a big resuscitator unit like this at the other side of the room, but you have to cut and clamp the cord to take the baby away. And of course, that's huge psychological implications for the mother as well. The idea is that once a woman gives birth and the baby comes out, if I'm the midwife here and I can see the baby's needing help, what I don't have the equipment and I don't have a stable platform for the baby. So I turn to this, I lift this off, and what it reveals, it's going to have a matching tray underneath which will contain all the equipment that I need. This then goes between the woman's legs, the baby goes on top of it. There's a heated pad here inside it, which you just click the button of. You slide it under the baby, and that'll provide the baby heating for an hour or so. You then have with you both a mask, which can give the newborn baby oxygen. You've got suction, which allows you then to suck out any secretions from the baby, and you've also got a way of monitoring the baby's heartbeat. And so you can very rapidly assess the baby, you can assess its breathing, but at the same time give oxygen as and when you need it.
In Mbale Regional Referral Hospital serves a population of 40 million people in Uganda. Of those, in a year we have 10,000 deliveries happening. That is an equivalent of 50 births a day. In the development of this neonatal, the BabySaver tray, with the funding from Grand Challenges Canada, and we're working with the University of Liverpool, Ministry of Health, to see that we refine a product that could be used. And if we develop it, our aim is that we could find that the money that could be used to buy one unit would be able to develop devices which could serve almost the entire country. This is transformational.
Hello, this is a talk on artificial intelligence in medicine. My name is Azzam Taktak. I'm a clinical scientist at the Royal Liverpool University Hospital. When the acronym AI is mentioned, people immediately think about sci-fi stories or movies. However, there are many examples of AI systems in use in our daily lives. There are many software packages or websites that do artificial recognition, facial recognition, for example, devices that look at traffic patterns and hotspots and suggest best routes, speech recognition systems, websites that recommend books, and more sophisticated systems like the Honda Asimo robot. Unfortunately, there has also been some bad examples of AI applications. One of the earliest AI applications is character recognition of handwritten numbers. We use such systems when we deposit checks in ATMs, for example. To create such system, we need thousands of patterns of digits between 0 and 9. We digitize them using an 8 by 8 pixel matrix, for example, as shown here, and feed them into a pattern recognition system which learns to classify any unseen patterns. In this example, an ideal system should guess that this pattern is closer to number 3 than any other pattern. Now, if we were to use conventional digital electronics and build a circuit for this task, we would need 64 inputs, one for each pixel, so that there is 1.8 times 10 to the 19 memory locations, which is 2 to the power 64. We need 10 bits in each location for the 10 digits. That means we require a whopping 170 million gigabytes. And even if such computers did exist, and it takes us on average 1 second to program a pattern, it will take us 600 billion years to program this memory. One of the simplest and most widely used AI systems is a perceptron. It has an input layer, 2 in this example, multiplies these by the W parameters, sums them up, adds a bias, and produces an output. It can be used to solve most linear problems, that is, patterns that can be separated reasonably well with a straight line, or a plane, or a hyperplane. The perceptron model in this example is used to mimic an AND gate. The W's shown here are one possible solution of many. We can see here that patterns with a target of 0 produce a negative number, whereas a target of 1 produces a positive number. So if we choose a threshold of 0, so that the model fires when it is above 0 and does not fire when it is below 0, we can produce the desired digital output with 100% accuracy. The perceptron unfortunately cannot be used to model the exclusive OR gate. To do this, we need something more sophisticated like a feed-forward neural network. It has a hidden layer with hidden nodes which performs a mathematical function called the activation function. The most widely used activation function is a sigmoid or logistic function shown in this slide. We can train this model, and any number of possible solutions for the W parameters may result. This is one possible solution. We can see that the network produces an output that is very close to the target in each case with a small error. This is a powerful model which can be used in many applications. One must be careful, however, not to overfit the model to noise in the data. Imagine this hypothetical example where we would like to classify the circles from the squares. If the data we collect contains noise so that one of the circles is misinterpreted with a square, a very complex neural network with many hidden nodes and layers might produce an output like this, which is undesirable since it is likely to misclassify some future patterns in this region here. To overcome this problem, we need to strike a compromise between how complicated the model is and how much error in the output we are willing to tolerate. This is achieved through a process called regularization. We have used artificial neural networks in many clinical applications in the past. One such application is detecting sleep patterns in children and classifying them into normal, movement artifact, periodic breathing, which is a benign condition, or an airway obstruction, which is a more serious clinical condition that requires intervention. To train the network, we took many examples from real recordings, classified them manually, extracted some statistical features from them, and fed these features into the neural network. We developed this further into a ventilator management system which clinicians can use to look at various physiological parameters, change ventilator settings, and get a prediction on the status of the baby in terms of their breathing, oxygen, and carbon dioxide levels. The development of this tool has led to many clinical applications. It was widely used in clinic and in research, and it was published in peer-reviewed journals. Other clinical applications we looked at was uveal melanoma, or cancer of the eye. This is a rare disease of which around half the patients go on to develop liver metastases, which is often fatal. It has been shown that a model which can predict those who are at high risk of developing metastases can improve quality of life for the patient. To do this, we developed an online tool called the Liverpool Uveal Melanoma Prognosticator Online, or LUMPO for short, using AI techniques. The tool has been thoroughly validated internally and published in scientific and clinical journals. The tool has also been externally validated using data from San Francisco and Poznan in Poland, and results of these studies were also published. We continue to develop and monitor the use of the tool. Google Analytics stats show us that there are 3,099 hits by March 2018 from 1,590 users in 68 countries around the world. Thank you for your attention.
Hi, my name is Murali. I am the lead clinical technologist as well as the site lead for clinical engineering at Newham. This is clinical engineering department. Newham Hospital is a part of a wider clinical engineering department of the trust, which is led by a senior management team, which comprises of head of the department and deputy head of clinical engineering and a governance lead, as well as a medical device lead trainer. Again, clinical engineering department is coming under a wider division called clinical physics, which is under a still wider unit called clinical support services. The core area of our activity is maintenance and repair of medical equipment here. We are looking after around 5,000 pieces of equipment all of the hospital here at Newham, out of which we are providing full in-house support to around 3,400 pieces of equipment at the moment. The department comprises of 4 staff members, including myself. We have all qualified, trained and experienced staff members to carry out this job in a safe and in a time-bound manner. The purpose and whole aim of this department is to ensure that all clinical departments in the hospital are having adequate number of equipment available for their clinical practice on a regular basis. We are making our best efforts towards this commitment by delivering this service by fixing the broken equipment in a minimum possible time, as well as servicing the equipment in line with the manufacturer's guidelines and making sure that they all are in service dates. In my role as a lead clinical technologist, I am leading and supporting all kinds of maintenance activities related to medical equipment here. I'm sure my colleagues will be able to share their experience happily.
Hello, my name is Ajit. I am one of the senior clinical technologists in this hospital. I have been in this role for more than 3 years now. As part of this role, I perform regular preventative maintenance on a lot of medical devices of varying complexity, such as these patient monitors. I've also performed PPM or repairs on increased complicated devices such as ventilators, incubators, defibrillators, to name a few. So that's the inspiratory pressure, or the that actually shows what's the pressure, the current pressure in this whole pneumatic system.
Part of my role, I also supervise my junior colleagues and assist them should they need help. Apart from providing such technical services, I am also involved in projects regarding medical equipment. I advise project managers on equipment that need to be bought for specific clinical purposes. I have also carried out medical device evaluations and helped clinical users to make the right decision while purchasing medical equipment of high value.
My passion for electronics has helped me to carry out a lot of repairs on complex medical equipment which would have cost a lot to replace otherwise. I believe that clinical engineers act as a linking bridge between clinical and technical professionals. I have had a lot of instances where I would meet with doctors and nurses to understand their clinical requirements and then advise them accordingly. I believe that as a clinical engineer, I have contributed a lot to improve the quality of human life, and as such I feel very proud to be a clinical engineer.
Hi, my name is Prathisan. I'm one of the clinical technologists here at Nottingham University Hospital. I joined this department in 2017. As a clinical technologist, I mainly concentrate on preventive and maintenance jobs, but it's not limited to that. I also work in trialing an equipment, accepting them and decommissioning it. One of the highlights of this role is we get to attend training sessions provided by manufacturers where we learn about a new equipment and how to service them and repair them. We also learn how to dismantle the equipment and completely reassemble them back. In addition to working independently, I also assist other senior clinical technologists with their corrective maintenance and preventive maintenance. So that helped me to gain first-hand experience in these devices even before I'm officially trained by the manufacturers. For example, this Calio incubator, I learned how to do preventive maintenance on it before I'm officially trained by the manufacturer. I'm also the quality rep for our department. As such, I make sure we are compliant with the quality standard ISO 9001-2015. This ensures we are working in a safe and secure environment. As a quality rep, I also attend monthly meetings for quality representatives where we discuss any quality-related issues raised and we discuss ways to resolve them. I'm also responsible for closing any non-conformances raised against us, as well as documenting any opportunities for improvement. I also get to perform internal audit in other departments within clinical physics. In conclusion, I would like to say not only we use our knowledge and experience on daily basis, we are constantly learning new skills. I can say for working for this department, I have gained a lot of valuable transferable skills such as communication, problem solving, and troubleshooting skills.
Hello, my name is Munaj Islam and I've been a healthcare science apprentice for the last 2 years. The transition from an apprentice to an assistant clinical technologist has really helped my personal development, as it has made me more independent. Due to this, I've been able to carry out a wider range of services and repairs. My favourite aspect of this is conversing with colleagues on the most effective way of carrying out services and repairs.
Hello everybody. Hello, my name is Azzam Taktak. I work in Silverton Ward. I'm a couple nurse down there. I've got a patient who's on IV fluid.
As well as servicing and repairs, I have to maintain an equipment library, which puts me in regular contact with hospital staff on a daily basis. This is a fun and exciting change of pace, and I've been enjoying every moment of it. When entering wards, it's essential to take proper infection control measures. This includes basic things like rolling up sleeves, removing jewellery, and washing hands with soap or antibacterial gel. It's essential that we do these things so that patient safety is maintained and there is a minimal chance of spreading infection.
Okay. Thank you very much. I will take this. Okay. Thank you very much. Thank you. See you later. See you later.
During my time at Nottingham University Hospital, I have learnt so much about clinical engineering, and I look forward to seeing the new things that I can learn in the future.
So that concludes our 4 UK presentations. If you'd like to follow up on any of the items introduced, please use the contacts presented within the talks themselves or through the IPEM as detailed in the footer of these slides. Thank you for listening.